many undergraduate and recent NEET PG pass outs have been contacting regarding how radiation oncology is a branch and how radiation oncologists work. So, the reason for this inquiry mostly is one, because during the 5.5 years of our MBBS, we have zero exposure to radiation oncology because oncology in itself is a super specialty field. So, if you see surgical oncology, gynec oncology, medical oncology, every oncology stream is a super specialty stream except radiation oncology. Now, before explaining the career perspectives and pros and cons of radiation oncology as a branch, I decided I'll just take you through my day, what a radiation oncology resident does in a day, which will give you a fairly better idea and I suppose the best idea of whether you should pursue it or not, because this is what you have to do for the rest of your life if you choose radiation oncology as a branch. So a typical day starts at around 6:30, 7 in the morning when you wake up, get ready, have some food, maybe not, and come directly to the hospital to take your ward rounds. Many people think that radiation oncology, there is very less patient interaction, but that is not true actually. The patients that we admit in the ward can be divided into three categories. First, they are receiving chemotherapy as a part of concurrent chemoradiotherapy because many malignancies have the standard treatment protocol as CTRT, that is concurrent chemo and radiation therapy. So we have to administer chemotherapy before the radiation therapy, and for that patient needs admission. Second are the patient who are admitted for supportive care. Supportive care as in they have received chemotherapy, second line, third line, they have received radiation therapy. Now they're on supportive care because they're on their supportive care to manage biochemical and hematological derangements. And I must tell you that is a lot of medicine work. Third category of patient are those with toxicities. Toxicities as in post radiation therapy and post chemotherapy toxicity. Now, after completing our first ward rounds, there is usually a second round which would be taken by our senior or our professors. Post completing your ward rounds, your day could proceed in either of the three directions. You can have your OPD on that day, you have a seminar on that day, or you follow up the patients, the previous patients who are on treatment, or they're coming for admission for their toxicities or chemotherapy. And in a usual week, we have 3 days of seminar and 3 days which are usually divided into OPDs and follow up clinics. Now, after completing this much of work, this is where the real action begins, where we do the procedures. Now, I'll take you one by one to what actually the procedures look like. And broadly, these procedures could be either brachytherapy or CT simulation. Now, brachytherapy in word itself means brachy means near or very close to, and therapy stands for the radiation therapy. So, this in wholesome means that delivering radiation therapy to the disease from very close or very near distance. And this is very commonly used in malignancies of cervix. This is just one such example. And for that, we need a operation theatre like status, and the patient is taken in a semi conscious or anesthetized state where we place the applicators. It is somewhat like a minor surgical procedure. So that procedure is done and patient is delivered the brachytherapy. Now I'll just give you a quick walkthrough of what the operation theatre setup and brachytherapy system in my institute looks like. So I'll be just taking you through the brachytherapy system and the operation theatre of my institute. This here is the waiting area where usually patients would be sitting around and waiting for their simulation or brachytherapy. This here is the operation theatre. And this here is the couch for the operation theatre. This setup particularly is for the cervical brachytherapy. The brachytherapy that we administer after completion of the external beam radiation therapy, brachytherapy is administered here. Now, taking you all to the just close it. I'll take you where actually the brachytherapy is administered. This here is the Bravos brachytherapy system. And you can see, as there is a radiation source present inside, power is not there. Now, as there is a radiation source inside, there is always a risk of exposure to the radiation. One, to the technicians and to the doctors as well. Now, patient would be lying down on this couch and the applicator would be placed inside the patient's body, which should be connected to this machine, which delivers the brachytherapy via a source. Going back. And this here you see the setup is like a maze-like setup. Maze as in bhul bhulaiya type ka. So you enter like this, you go like this, and then you enter like this. That is to prevent the radiation from coming outside the delivery room. Just close it. And turn off the lights. Okay. Now one procedure is done, that is the brachytherapy for the day. We have usually 2 to 3 patients per unit, and we have a total of 4 units. So nearly about 12 to 15 brachytherapy we deliver every day. Now, post completion of brachytherapy, we move on to the simulation of the patient. Now, what exactly is the simulation? This was brachytherapy, giving the radiation therapy from a very close distance. Next thing is EBRT, external beam radiation therapy. That is what the actual radiation therapy is. So for that, we need to simulate the patient. And I'll just take you to the machine where the simulation is done, and there I'll explain in a step-by-step manner when the patient comes to us, then how do we simulate and how do we treat. The whole process I'll be explaining in this video. Coming out of the brachytherapy delivery room, we go back again to the waiting area. Usually this whole corridor is full. Now, this here is the CT Sim Somatom. This is here the simulation system of our institute. Here all the computers and the system which controls the simulation machine. This is a ring simulator, ring CT simulator. I'll just explain how this works, but here you can see this also has X-ray radiation. Now, when we go inside the machine, we see a couch, which is a flat couch, and a ring simulation system. This is very similar to a CT scan machine, and you can say exactly we are taking the CT scan of the patient. Now, why we are taking the CT scan of the patient is we'll replicate the same position we are creating in the simulation room as in the treatment room, so that there is very less chance of error, or specifically we just eliminate the error in wholesome. So the patient would be lying down here, and then we'll take a CT scan image. The couch moves inside and through the gantry. The only difference between the CT simulation ring and CT scan ring is that the bore size, ये जो छेद है, ये जो गोला है, this is very big in the simulation to adjust for the positioning of the patient, and the couch here is flat as well, whereas CT scan में थोड़ा couch curved होता है. So this here is a CT simulation machine of our institute. Now, the things that you see here, these are the thermoplastic casts or ORFITs, what we call them. This is to immobilize the head and neck cancer patients. And this one here is for stabilizing abdominal malignancies, stabilizing patients with abdominal malignancies. So this is an abdominal thermoplastic cast or ORFIT, abdominal ORFIT. And this one here is for CNS malignancies, so for the brain malignancies. Now, moving outside the CT simulation room, once the simulation of the patient is completed, the image is generated. I'll just close it. So, you see, outside every room there is a X-ray radiation caution board. The only drawback of this, I must say, or relative drawback of this branch, radiation oncology, is radiation exposure. But that is a relative drawback. The technology is so advanced that the radiation dose delivered is very contained, and exposure to the technicians and physicians is very less. And I must say it is within the normal acceptable limits. So now the image generated here, what we took from the CT simulation, now this image, this data is sent to the contouring system. Now I'll tell you where the contouring system is. That was where I was first recording the video. I'll just show it. This here is a contouring station. What essentially we have in the contouring station is a system, a very advanced system, and I'll just show you how contouring looks like. Just a second. I'll just randomly open some patients' data. And if you're following me on Instagram or YouTube, you already know what contouring is. I am sharing very small shots there of the contouring images. If you're not, kindly follow me there. So I'll just open any patient. So these images, the CT scan image which you're seeing is being generated in the CT simulation room, and then it is transferred here. And what we essentially do is draw these contours. You see, these all. We are going to draw looking at the CT scan images, and we are drawing. The GTV here is the gross tumor volume, and CTV is the clinical target volume, and PTV is the planning target volume. You'll get to know once you join what in the radiation oncology what all these means. So this is basically where we are going to deliver the radiation. The PTV would be receiving the radiation, and the dose is also written here 70 gray. That will be receiving 70 gray in 28 fractions. This here is a prostate. Yeah, it's a prostate case. Now, moving on, once we have contoured here, the contouring is done, this data is then transferred to the treatment and planning system. And treatment and planning system is the area of work for the physicist. So, this chamber is primarily occupied by the physicist, medical physicist. They'll work here, they'll plan how the dose beams, how the radiation beams are to be placed so that the target achieves the maximum dose, and the nearby structures. Like in the case of prostate, we saw bladder should receive very less dose, rectum should receive less dose, but the prostate in particular should receive a good amount of dose. So this is where physicists work. Now, after the planning is done, I'll just show you the planning, what planning looks like in that particular image only. So after the planning is done, the radiation oncologist will evaluate the plan. I think the plan for this case is done. Yes. I'll just open the plan. See, the plan is done. So this color wash area is based upon what radiation dose is being delivered, and these are the beam placements, these purple lines you're seeing. So it is very difficult to explain in a video how does this work. For that you will have to join radiation oncology. Now this plan is being assessed by the radiation oncologist. Here you can see the dose. The radiation oncologist will see the coverage of the radiation delivered, whether it is covered full or not, and appropriate dose is delivered to the target or not, and organs at risk like femur is at risk, rectum is at risk, whether they are receiving dose in a particular constraint or not, whether the dose constraint is achieved or not. If all of this is okay, coverage is okay, target dosage delivery is perfect, OARs, organs at risk, are receiving less dose, the plan is approved and the patient is sent to treatment. But if any of this is not working out, we have to tell medical physicists to plan again. So then they replan it, then they again evaluate, and then the patient is sent for treatment. Now after this, the patient is transferred to the treatment delivery system, which is the most advanced linear accelerator. I'm just going to show you how a linear accelerator looks like and its basic functioning. So let me just take you there. So in our institute, we have a total of, this door is locked. I'll just take you from the another corridor. So in our institute, we have a total of 4 linear accelerators. हाँ कर दें तो सर mostly because of the night time, the securities are closing down everything. This was the door we were supposed to come from, but it's locked. Now, these are the linear accelerators. This here is the physics lab where the technicians would be sitting. They'll be placing in the patients, setuping the patients, and the radiation oncologist comes and he'll see this here is the entry of the linear accelerator. It's beautiful, isn't it? Then again, the maze-like setup. The maze-like setup ensures that there is no radiation leakage outside of the radiation delivery room. Now this here is a linear accelerator. Again, this is the same couch as we saw in the CT simulation room. It is flat. This here is a drum linear accelerator, and this is called the gantry, drum gantry. And from here, the radiation is delivered. This couch particularly has various range of motions. It can move up, down, front, back, rotate as well. And this here is not only the setup, we have this huge setup inside. Now, the energy which we are particularly using in linear accelerators at our institute is the photon energy. Previously, we were using cobalt machine. We have that machine as well. So we have a total of 1 cobalt machine and 4 linear accelerators. But in the linear accelerator, the photon energy is generated from an electron gun. And this whole machine setup is comprising of electron gun and various other things which generate the photons, which are basically the X-ray energy packets which deliver the radiation to the patient. So this here is the electron gun. There would be written somewhere. Electron gun. Ulta likha hua hai, electron gun. And this here inside has a wave guide and various other things which are not important. The treatment is scheduled in fractions. जैसा मैंने दिखाया था in the planning system, 70 gray was advised to the patient, but 70 gray won't be delivered at once. This would be delivered in fractions. So patient has to come regularly, daily even, for 1.5 months, every day to get his fractionation done. This is how from the starting, OPD से लेकर treatment starting तक, what a radiation oncologist does. So now coming back to our discussion, who should take radiation oncology as a branch? One, if you're liking what I do in the whole day, अभी तक मैंने जो आपको बताया, if you like it, you can definitely consider for radiation oncology as a branch. Second, if you love medicine and physics both. Second thing to consider is patient interaction. बहुत सारे लोगों को ये लगता है कि रेडिएशन ऑन्कोलॉजी में पेशेंट इंटरैक्शन नहीं है, बट आई टेल यू द कॉन्ट्ररी. देयर इज अ लाइफ लॉन्ग पेशेंट इंटरैक्शन. वंस अ पेशेंट विल ऑलवेज बी अ पेशेंट. सपोज अ पेशेंट कम्स, कार्सिनोमा हेड नेक बकल म्यूकोसा का केस है, and you plan a radiation therapy with concurrent chemotherapy for it, radical. The patient is cured. Now you'll have to follow up the patient for the rest of his life so that the recurrence does not occur. So once a patient comes to you, you treat him for 1.5 months, then you call him one back, then you call him after 1 month, then every 3 months for 2 years, then every 6 monthly for next 6 years. So for the rest of his life, he will be coming back to you. So there is a lot of patient interaction. So as compared to other branches like medicine या gynae, बहुत सारे पेशेंट से इंटरेक्शन नहीं है, लेकिन एक ही पेशेंट से बहुत सारा इंटरेक्शन है. नेक्स्ट थिंग इज वर्क लाइफ बैलेंस. रेडिएशन ऑन्कोलॉजिस्ट यूजुअली डोंट गेट अ इमरजेंसी कॉल. इमरजेंसी शिफ्ट जैसी चीज रेसिडेंट्स की तो होती है, बट वंस यू आर प्रोफेशनल, hardly in a month you'll get 1 or 2 calls with a toxicity for chemotherapy या radiation therapy जो actually emergency situation होगी. So work-life balance is quite good. And lastly, if you want to consider for medical oncology, now medical oncology is a DM branch. जैसा मैंने बताया था, सारी oncology branches DM branches हैं. But if you want to consider for medical oncology, one path is to take radiation oncology where you get a very good oncologic exposure and then pursue medical oncology. Rather than as compared with medicine, जो कि एक superficial branch है, एक general branch है, you get to know about everything थोड़ा थोड़ा सा, and oncology part is very less. And then when you enter into the medical oncology as DM post medicine, then your oncology exposure suddenly becomes so much. तो एक drastic shift होता है. Maybe everybody is accommodating with that shift, but once you pursue radiation oncology and then medical oncology, you already have a very good idea of what medical oncology is, because radiation oncologists भी chemotherapy देते हैं. It's just that medical oncology as a branch is evolving and introducing immunotherapies and very specific treatments. Then it is considered as a DM branch. Now the next part of this topic, which is The future of radiation oncology. Future is very bright. Particularly in India, this branch is very unexplored. टायर 1 सिटीज में तो ठीक है रेडिएशन ऑन्कोलॉजी सेटअप्स है, टायर 2 और टायर 3 में रेडिएशन ऑन्कोलॉजी सेटअप्स आना बाकी हैं. Like for example, I am working in Cuttack. My hospital is in Cuttack. Cuttack per se has Bhubaneswar and Cuttack. These have radiation setups. Linear accelerators are there. But when you go to the periphery, there is no other city except Bhubaneswar and Cuttack in whole of Odisha which has a linear accelerator. So tier 1 cities is having it. Tier 2 and 3 still ana baki hai. So the scope is expanding. Second, in radiation oncology, we have something called as radiosurgery. Yes, surgery with radiation. अब इस surgery में we don't have to cut open the patients. So the places like brain जहाँ पे बहुत ज़्यादा morbidity है, surgery per se ही we can use radiosurgery. So this is called SRS, stereotactic radiosurgery. या फिर liver, stereotactic body radiotherapy. These all solves the problem जितना कि एक सर्जरी से हो सकता है with minimally invasive. This machine precisely targeting the tumor or whatever it is that you have to target. Benign diseases जैसे कि trigeminal neuralgia, radiation therapy has a big role. Radiation therapy has a role in benign and definitely malignant diseases. And in future, you see it replacing surgery at some places where surgeons cannot even reach. Now discussing the earnings of a radiation oncologist. मैं मेरी अर्निंग सबसे लास्ट में बताता हूँ एज अ रेसिडेंट. First, I'll discuss once you pass out of the radiation oncology and you join a government setup, a medical college, a government hospital, or a government setup, you are essentially employed at 1.5 lakhs initially to 2 lakhs as the joining salary. That is your joining salary, 1.5 to 2 lakhs comfortably. But provided many states do not allow private practice, so that is a cap. 1.5 to 2 lakhs is your cap, monthly cap in a government job. Now, if you decide to join a private hospital, then your starting salary would be somewhere around 1.7 to 2.5 lakhs per month. That also has a cap because you joined the private hospital. Now they'll be paying you salary. Next is you can do freelancing. You open your oncology clinic, you have the patient influx, then you take the patient into the hospitals where they have radiation setups. They won't disagree or they won't say कि नहीं हमारे यहाँ मत लेके आओ. They need patients. So when you take patients, you treat them and you get a treating amount for that patient. I'll just explain this with an example. For example, carcinoma cervix में एक average price जो है treatment का concurrent chemo radiation therapy का, that is for the whole treatment it's 1.5 lakhs. So if you're taking a patient to a private hospital, but you're not appointed in that hospital, you're just going for the treatment, you're going for the usage of the machine, you're giving the hospital the patient, you're giving hospital the influx. So when you go, the hospital will charge. They have a package, they'll charge 1 to 1.5 lakhs. And from that 1 to 1.5 lakhs, a doctor gets 30 to 40%. So per case, you'll be getting around 40 to 50,000 rupees. Hi, welcome back. Sorry, last video record करते करते battery discharge हो गई थी. But to conclude the video, I would say I think I've covered most of the topics relating to radiation oncology as a branch. आपको लेनी चाहिए या नहीं लेनी चाहिए? What are the pros and what are the cons? So that's it for this video. अगर इसके अलावा भी आपके कुछ doubts हैं relating to oncology as a career option after MBBS in your PG selection and your NEET PG counseling, आप वो मुझे comments कर सकते हैं नीचे. मैं कोशिश करूँगा सबका रिप्लाई करने की, या फिर आप मुझे इंस्टाग्राम पर डायरेक्ट डीएम कर सकते हैं, वहां पर मैं थोड़ा जल्दी रिप्लाई कर पाता हूँ. थैंक्स फॉर वॉचिंग द वीडियो गाइज. आई रिक्वेस्ट यू कि आप शेयर करें ये वीडियो अपने कॉलेज के ग्रुप में ताकि मैक्सिमम से मैक्सिमम लोग जान सकें इस ब्रांच के बारे में. थैंक्स.